Good afternoon and welcome to the North Shore Outcomes Research Seminar in the 14th in our COVID-19 research series. Today, Dr. Michael Eisen will be presenting his research on COVID-19 oral antiviral therapeutics. We'll also be joined by an expert panel, including Dr. Amanda Kaplan and Dr. Maggie Collison from the North Shore University Health System and Dr. Savash Tay from the University of Chicago. And today, 2 years into this pandemic, we have experienced over 6 million total deaths and over 500 million cases worldwide. It is a very timely topic to talk about oral antiviral therapeutics, given that we're also seeing a spike in the COVID-19 BA.2 variant. So today we'll be joined by an expert in infectious disease from the University of Chicago who will be presenting his work. I'd like to start off by thanking all first responders and everyone working on the front lines during this pandemic, to our Director of Outcomes Research, Dr. Bernard Ewigman, to our program directors, and to the North Shore leadership for sponsoring and for the ongoing support to make this seminar happen, as well as our speakers today. Next, Rachel will be sharing a brief Zoom orientation slide to explain how to navigate the webinar today. Rachel?
Thank you so much, Dr. David, and hello, everybody. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen.
Recording in progress.
Sorry about that, everybody. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone on the webinar. Please feel free to leave your questions and comments at any point during the presentation. If you are experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you as best I can. Okay, I'll hand it back to Dr. David, who will go over the agenda for the day.
Thank you very much, Rachel. Next slide. All right, so today, following our introduction, we're going to be having a presenter who is unable to join us live today because of a conflict involving some travel, but Dr. Eisen's presentation will be a recorded presentation that will be just a little short of half an hour. Following that, I'll be welcoming comments and questions that we can feed to the actual expert panel as Dr. Eisen is unable to join us today. And we will, following that, have our Incubator Hub expert panel discussion. So I encourage you throughout the talk, if you think of any questions, to go ahead and put those into the comments. And we will collect those, and Rachel will also feed those questions to our expert panel. And the same will go for the Incubator Hub expert panel discussion, at which point we're going to ask you to send comments that which we can bring to the presenters, and that will add to a robust discussion about the health equity, clinical policy, and translational science implications of the work. Following that, I'll provide some closing remarks, and then we'll provide a link to an evaluation and then the YouTube channel so that you can share that with your colleagues who are unable to make the seminar today. All right, Rachel, thank you very much. So our presenter today is Dr. Michael Eisen, who is a physician scientist, and he's a professor of medicine and infectious diseases and a professor of surgery and organ and transplantation at the Northwestern University Feinberg School of Medicine. Dr. Eisen was kind enough to record his presentation in advance, and he apologizes for not being able to be here in person. But I would like to extend a warm and gracious welcome to Dr. Eisen for his presentation today.
Hello, my name is Mike Eisen. I want to apologize for not being able to be live at the meeting. A trip that required me to be out of town came up conflicting with the meeting. It's an honor to talk with you today about an overview of drug treatment for COVID-19 with a focus on the outpatient side of care. Here are my disclosures. So I thought I would start with kind of setting the what we know about COVID-19 in terms of natural history and thinking about where our therapeutics would fit in. What we have seen is that early after the infection, you have a period of time where viral replication slightly increases. Patients initially are mildly symptomatic or completely asymptomatic with progressive development of symptoms. During this early phase, most of the clinical illness is derived from the virus, and so antiviral therapies would be of greatest benefit during this period. As disease progresses, the host immune response begins to respond to the viral replication in an attempt to control replication. This results in progression of the clinical disease to develop development of lower respiratory tract symptoms, driven in part by virus, but oftentimes more significantly by host immune responses. There may still be a role for antivirals, but the host immune response inhibitors are where the focus of therapy is generally at. As patients get sicker, there's less and less virus driving the course, and the host immune response becomes overly aggressive, and modulators of the host immune response are really what are needed to improve clinical outcomes. So based on this kind of framework of clinical disease, this has led the NIH and other guideline groups to really think about where patients are clinically in the disease course. Some of this is arbitrary. Just because someone is within the confines of the hospital doesn't necessarily mean they have severe COVID. They may be admitted for other reasons. It may be just that their phenotype, for example, being immunocompromised, is having them be admitted for observation. But nonetheless, these generally formulate populations relative to stages of clinical illness. Early on, before illness begins, there's ways that some of our therapies, including monoclonal antibodies, can be leveraged to prevent infection, something that I won't be spending much time talking about today. Early, particularly those with exposure, you can use post-exposure prophylaxis, not currently an option with the currently authorized monoclonal antibodies. Once patients develop illness, but not severe enough to drive them into the hospital, there's a range of therapeutics focused on antiviral activity, either monoclonal antibodies or oral antivirals. As patients become more sick, this is where we start thinking about remdesivir, either in patients as an outpatient, or more likely those patients with milder disease in the hospital. As they become sicker, requiring more oxygen or requiring ICU level care, this is where we think of the addition of things like dexamethasone or one of the anti-inflammatory agents like tocilizumab or baricitinib. But we're going to be focusing today on outpatient management of COVID-19. And to date, our primary objective for these patients is to prevent hospitalization. The mainstay of the therapies up until very recently have been the monoclonal antibodies. And these bind in a number of different locations shown here with the spike protein in the middle, with the various site of binding of the various classes of medications. Where these bind, whether they're on the surface of the receptor binding domain, which is more likely to mutate, versus areas that are more distant from the RBD, predict the ability of these monoclonal antibodies to be effective despite changes in the RBD. And these changes have really resulted in significant efficacy in terms of neutralization and clinical outcomes. With the advent of the Omicron variant in the end of last year, we saw loss of most of our monoclonal antibodies with the exception of sotrovimab or S309. Looking at these graphs, the blue lines are the patients that are virus with the Omicron mutations, whereas the black is the wild type Wuhan virus. And you can see as you shift these lines out, and in some cases become a very flat curve, meaning that you're not neutralizing the virus in any way, shape, or form. We've lost some of our mainstay therapies, BAM-EDI, REGEN-COV, all kind of got taken out with Omicron. The initial Omicron, though, did retain activity of all of our oral and IV antiviral therapies and retained activity for sotrovimab. Unfortunately, BA.2, which has emerged and become the predominant strain in the United States, has further knocked down our armamentarium with an increase in neutralization for sotrovimab, resulting in it not any longer being favored as therapy for our patients. Thankfully, the in vitro activity of remdesivir, molnupiravir, and nirmatrelvir remain stable and can be still relied upon for the Omicron variant, in part because their target is different from the target of the monoclonal antibodies overall. Sotrovimab was our workhorse up until very recently. It was associated with a significant reduction in the risk of hospitalization or death in patients, particularly those at high risk of complications and those presenting early after disease onset. One of the real challenges, though, are that all of these studies that we look to for the monoclonal antibodies were performed in a time period with earlier variants from the one that we see currently, and generally in unvaccinated patient populations. As a result, we have to interpolate from existing severity data, as well as this data prior to Omicron and in mostly vaccinated patients, to decide which patients receive the greatest benefit in terms of outcomes for therapy. This study really looked at patients in terms of their overall improvement. And you can see that really it's those patients that are at highest risk of complications, those that have 3 or more risk factors, seem to be the ones that, even with vaccine, achieve significant clinical benefit with the receipt of monoclonal antibodies. As I'll talk a little later in the talk, this has led us at Northwestern to limiting monoclonal antibodies in patients that are vaccinated to those with 3 or more risk factors. One of the key challenges with sotrovimab and all of the monoclonal antibodies is the emergence of resistance. What we've seen, and this is just one recent study that looked at the development of resistance, that particularly among immunocompromised patients that have a known longer duration of viral shedding, the use of sotrovimab does improve clinical outcomes, but these patients, in spite of the sotrovimab, may continue to have longer durations of viral replication. This is particularly true in patients that have issues related to antibody production, such as patients with myeloproliferative disorders, CVID, and receipt of B-cell active agents like rituximab. Over a short period of time, resistance can emerge in which the drug becomes less active, less able to neutralize the resistant variant, and potentially could transmit on to other individuals. Interestingly, when these resistant variants emerge, oftentimes there's a rebound in viral replication, and in some patients, a worsening in clinical symptomatology. As mentioned, with the loss of sotrovimab, now with the emergency use authorization restricted for sotrovimab, we're left with bebtelovimab as our only active monoclonal antibody. A couple things that we need to recognize is that this drug has very limited clinical efficacy. The study that was performed looked at BAM-EDI plus bebtelovimab versus bebtelovimab alone. It's found similar efficacy between these two groups, again with non-Omicron variants as the study population. Beyond that, there's not a lot of clinical benefit, and even in relatively healthy patients, there's about a 5% incidence of resistance emergence. So while this has become our backbone, I think this is something that we clearly need more more clinical data on safety and efficacy of this compound. Thankfully, oral therapies have been developed. The first that has gained the most attention is nirmatrelvir, which is co-formulated with ritonavir, and it's an oral protease inhibitor. The way that this works is you have the protease shown here, kind of like the Pac-Man, the protease inhibitor shown in the spike. When the patient is dosed with the medication, that spike inhibits the protease from being able to digest the polypeptide into the individual components of protein that are required for replication of the virus. Unfortunately, nirmatrelvir is very rapidly degraded and requires co-formulation with ritonavir to make it maintain bioavailability throughout the dosing interval. Because of the addition of ritonavir, it has significant drug-drug interactions, which has really hamstrung the use of this agent. The study leading to the authorization of this medication is shown here. It was a study in which patients that were the PCR or antigen positive with symptom onset within 5 days and at least one risk factor for severe disease were dosed with either the study drug or placebo twice a day, with the primary outcome being hospitalization for greater 24 hours or death within the first 29 days. As you can see, there's very rapid separation over the first week between the drug-treated patient population and the placebo-treated population. While the absolute risk reduction was relatively small, this was associated with about a 95% reduction in the risk of hospitalization and death. Benefit was seen in all treatment groups, a slightly greater benefit in older adults, in patients that were seronegative, suggesting that there may be less activity in patients that were previously vaccinated, and again, slightly greater benefit in those patients that had more risk factors. Of note, there wasn't great benefit when added in combination to monoclonal antibodies, and this leads to the current recommendation that you select either an oral therapy or monoclonal antibodies. There was slightly faster clearance of virus with the medication compared to placebo, but really its antiviral effect as measured in the nasal swab really was far from optimal. The second drug that initially I think had garnered a lot of interest and attention, molnupiravir, is kind of interesting in that it's a pan-RNA antiviral, meaning that it has activity against all of the respiratory viruses, not just SARS-CoV-2. It's phosphorylated intracellularly to NHC triphosphate, which is then incorporated into the viral RNA. This results in substitutions whenever there is a guanosine or adenosine present, such that you get switching to the alternative when the molnupiravir is introduced. This results in massive mutagenesis of the virus, resulting in inability for the virus to actively replicate. The study looking at this again in the pre-Omicron era required patients that were PCR or antigen positive with symptoms onset within 5 days, symptomatic with at least one risk factor for severe disease. They received 4 tablets of molnupiravir twice a day or matched placebo. Primary outcome, like the prior study, was hospitalization or death within 29 days. Unfortunately, the drug, while it did reduce the frequency of hospitalization and death, the benefit was much less, about 35% overall reduction in the risk of hospitalization and death, with similar outcome irrespective of the subgroups or risk factors. Despite the relatively modest benefit of this drug, it still has a role, particularly in those patients that may have a contraindication to Paxlovid, who aren't as high risk and may form the backbone of some of our therapy in the future, particularly as we think about things such as combination therapy. Now, there's been a lot of talk and discussion about the risk of resistance with molnupiravir, but I personally think that there's been too little emphasis on the potential risk with nirmatrelvir, which we know the 3C proteases are very susceptible to resistance emergence. It's been clearly shown that this class of drug develops resistance very quickly and frequently for other treatment of other coronaviral diseases. And really, people haven't been looking to a great extent at the frequency of resistance. And so I'm far more worried about emergence of resistance with Paxlovid or nirmatrelvir than I am with molnupiravir. But in fact, perhaps the approach that we should be using is a combination of these two, something that's not currently authorized. Remdesivir was studied in an outpatient population, again, a very similar study design, PCR or antigen positive with symptom onset within 7 days, and at least one risk factor for severe disease. Patients got 200 milligrams of remdesivir IV day 1 and 100 milligrams on day 2 or 3 versus IV placebo, as listed above. Hospitalization for more than 24 hours or death within 28 days was the primary outcome. And as you can see, again, this wonderful reduction with remdesivir with the about a 85% reduction in overall cases. While an interesting approach, it really can't very well be implemented. It takes a lot of time and effort. Patients have to come back to a clinical center for 3 days. And if there's sufficient supply of monoclonal antibody, I see no reason why remdesivir would be offered as long as there was adequate supply of monoclonal antibodies, because you can treat 3 monoclonal patients for every 1 remdesivir patient, since it takes about an hour for infusion for both. Now, our biggest challenge is that our goal to date has been to reduce admission and deaths. The challenge is that vaccine efficacy has markedly reduced the likelihood of hospitalization and death, particularly in patients that have been boosted, even against Omicron. Again, you've got about a 90% reduction in the risk of hospitalization, 95% reduction in the risk of death. And so that means that the delta that you would achieve with some of these therapies is going to be markedly reduced. Additionally, what we've seen, and this is data from Northwestern, is that the severity of Omicron is clearly less. Only about 5% of patients with Omicron are being admitted compared to 14% of Delta and 20% with Beta. Proportion requiring oxygen is about half what it was with prior variants. Again, about half the risk of severe disease and a much lower proportion of fatal cases with Omicron. So again, if our target is to reduce the hospitalization or death, that target has markedly dropped, meaning that we're going to need to treat a lot more patients to achieve that benefit. And so it really begins to beg the question, which patients should we be treating? And this is further challenged because there's no mechanism to collect real-world data on authorized drugs. These patients, while they're experimental therapies, are not appropriately consented to collect real-time data. There's no current effort to assess frequency of resistance emergence. We don't have any real-time data to inform efficacy of these therapies as new variants emerge. And this is important because, as we saw with the onset of Omicron, we had some states demanding the use for drugs that really didn't work. But since we didn't have the clinical data to show that, they could still, unfortunately, complain that the federal government was cutting them off from therapy that they thought would be of benefit. Additionally, there's no data on off-target populations. Again, all of these studies were in unvaccinated patients. We have no data in vaccinated patients to inform which populations we should be targeting. Likewise, all studies conducted to date enrolled subjects, unlike the majority of patients we're seeing today. All enrolled studies were unvaccinated. Most were with Alpha or Delta. And then the correlates of clinical impact with fold change reduction and neutralization haven't been well defined. We have set a threshold for where we think there'd be a clinical deficit, but we don't know if that threshold is a 20-fold increase, a 40-fold increase, or a 100-fold increase. And really, again, this is important. We're throwing out drugs without having that clinical data to tell us where the therapeutic benefit drops. As a result, we've had to kind of integrate data on disease severity, as well as likelihood to be hospitalized or develop severe disease. As a result, we've developed, as most centers have, a tiered approach to use of monoclonal antibodies at Northwestern. We developed these tiers with different subsegments so that as numbers went up and capacity was limited, we could further constrain the population that was eligible to receive therapy. Currently, we are allocating drug to patients in Tier 1 and Tier 2. Tier 1 are patients that meet the CDC definition for moderately and severely immunocompromised, unvaccinated individuals with 3 or more risk factors, and unvaccinated pregnant women with 1 or more risk factors. This was our old tiering system. Now all patients have to be within 7 days from symptom onset. It also now includes Tier 2, patients that are vaccinated with 3 or more risk factors. The big question that we've been asking is, are there other subgroups that we should be thinking about? Patients that are older, particularly over 75, and to a lesser extent above 65, still have a relatively high rate of hospitalization and death despite vaccination. So perhaps they should be potentially prioritized for therapy. Thinking about how we prioritize and think through our monoclonal antibodies. The monoclonal antibodies, initially sotrovimab, now we just as of a week ago switched over to bebtelovimab, is our workhorse for immunocompromised patients because these patients typically are on medications that interact with ritonavir. Patients with 3 or more risk factors and medications that interact with ritonavir, and that these can only be now used for 7 days after symptom onset. For most patients, the preferred therapy is nirmatrelvir, ritonavir. It should not be used in immunocompromised patients because of drug-drug interaction challenges. We can use it in patients without interacting medications. It does have to be dose adjusted for renal dysfunction and can only be used within 5 days of symptom onset. And then molnupiravir is kind of our third line therapy for patients that don't meet criteria for monoclonal antibodies or Paxlovid. It could be considered an alternative unless the patient is pregnant or planning to become pregnant. Likewise, it needs to be delivered within the first 5 days after symptom onset. As you can see, I didn't really include remdesivir. We decided not to use that on the outpatient side, in part because of significant logistic challenges and adequate, for now, supplies of monoclonal antibodies that allow us to prioritize treating 3 patients with bebtelovimab versus for every 1 patient would be treating with remdesivir. But nonetheless, I think the therapeutic strategies that we have are as outlined here, with a priority for those with interacting medications for monoclonals. Next, Paxlovid, because of the greatest therapeutic benefit, more similar to the monoclonal antibodies. And molnupiravir is our third choice in patients that aren't eligible for one of the other 2 therapies. It's been a huge honor to talk with you today, and I wish I could be present for questions, but people can contact me offline, and I'll be happy to answer any questions that I have. Thank you, and have a wonderful day.
All right, thank you so much. And we send thanks to Dr. Isom for that great presentation. At this time, we can take a few questions from our listeners. As stated earlier, please input any questions in the chat box by addressing it to the panelists and attendees so everyone can be involved. And while Dr. Eisen couldn't be here today live to field questions, please feel free to contact Dr. Eisen at his email shown on screen. Okay, I'll give people a moment to enter their questions and we can get started. All right. Let's see, Dr. David posed the question to panelists. Will monoclonal antibodies need to be, or can they be updated on an annual basis like the flu vaccine?
I don't know if I'm the best one to answer that question, but I think it depends on, especially for monoclonal antibodies, where it is binding to the spike protein. We know with bebtelovimab, it's binding in a position that hasn't been mutated as much, whereas the previous versions were attaching to highly mutated portions of the spike protein receptors. So I think the hope is that we get to the point where we have something that can't mutate.
Okay, and our last question from Dr. David is the issue of prioritization of patients based on evidence of efficacy, efficacious yes or no, for different risk groups or relative benefit, i.e. higher risk patients have higher morbidity if untreated, so relative benefit is more. Is that right?
So if the question, so just also to simplify the question, there's benefit for most or all groups of patients, but relative benefit is greater for high-risk patients. Is that true for each of these treatments, or is it that they only have been shown to be efficacious in high-risk groups?
I can take a stab at that, this is Maggie. And then Dr. Kaplan, if you have anything to add, because I know you were a little bit more involved with that. So I think the idea is that those should be the patients who would benefit the most, because if you are in these higher risk categories, ideally, if you're getting those medications, that's kind of who we would expect to be most likely to be hospitalized compared to like a 25-year-old with no comorbidities. We're not seeing in general, a large majority of those people being hospitalized. So like the risk of being on a new medication probably could more outweigh the benefit. So I don't know if that kind of answers the question, but then I do know also, there have been different allocations and that I've not been completely the expert on, but I know speaking with our pharmacy colleagues and my infection prevention and stewardship colleagues, that definitely was, it is becoming more available, but there were still a lot of concerns on having to try to allocate that, especially initially with these medications. So I don't know if anybody else wants to add to that, but I think it's sort of a combination.
So, right. So then if there's a 25-year-old patient with no risk factors who gets Paxlovid, is it that there's no reduction in duration of their symptoms at all that's statistically significant, or is it that the relative benefit is not as big as for someone who has multiple risk factors and is over 70 and so forth? That's kind of what I'm wondering. Or it sounds like it's kind of a continuous line, and at some point it becomes cost effective and rational to treat patients based on relative benefit and risk. Is that about right?
So I think we need to look at what the studies were based on. So the primary endpoint for almost all of the studies of these medications was hospitalization or death. There is some ongoing secondary endpoints looking at symptom reduction, but all of these studies were based on hospitalization and death. So until we have more robust studies showing that it does improve either length of symptoms or severity of symptoms, at this point it doesn't really make any sense to treat anyone with these experimental medications who is not at risk for hospitalization or death until we have more studies to show it's beneficial.
Yeah, thank you. And Dr. Kaplan, you posed a question as well. Is that right?
I just thought she needed more.
Yeah. So Rachel, do you see the question? So the question is what's going to happen, what will be needed for these treatments to be fully FDA approved once the EUA expires, once emergency status for the nation ends? Will there be a period when they are not available to use pending clinical trials to justify FDA approval? Or what do you, as infectious disease specialists, anticipate?
You know what, honestly, I have to actually look into more detail. I know Dr. Eisen he had talked a little bit with us about that last week. I'm not sure the exact details of when the FDA, like how they would have to meet to that. I think they would have to have another evaluation to formally approve it. But I mean, they did review all the data to give it the EUA, but there's just a little bit more nuances that I'm just not as familiar with. I don't know if Dr. Kaplan or anybody else on here is. And I can definitely ask and can always email you when I ask some of our pharmacy colleagues.
Yeah, okay. All right, and are there other questions, Rachel?
No other questions at this time.
Okay. And another, well, I have another question, which is that we do see that there are some adverse events that happen, but can you comment on what some of the common adverse events are and what some of the common side effects are for say Paxlovid or any of the other ambulatory treatments?
Yeah, so for monoclonal antibodies especially, which I have more experience with, there's about a 1% chance of or 1 to 2% chance of a local reaction. So we saw a lot of redness around the injection sites, especially when we were doing the sub-Q administration for Regeneron, a little redness around the IV sites. And then I think the studies were quoting about a 1% chance of a more significant allergic reaction. We had a few patients who developed generalized itching, things like that. We saw that more in our patients who came in with really high levels of allergies to multiple different agents prior to receiving. It was pretty unusual in patients who didn't have a significant allergy history coming in. For Paxlovid, seen some interesting side effects. I had someone who said they had just had a horrible taste in their mouth for the duration, some expected kind of nausea and upset stomach. And then, of course, there are some more significant potential kidney interactions with the Paxlovid, but those have been what have been reported to me from patients.
Very good.
Okay, looks like that's all that we have for our questions right now. So we'll hand it over to you, Dr. David, for our expert panel.
Thank you very much, Rachel. And I should also introduce both of us. Rachel Brewington is the administrator for the Outcomes Research Network, and and she is my partner in this seminar. And I'm Sean David, Program Director for Translational Science in the Outcomes Research Network. And we are delighted to welcome our expert panel today. Today we have Dr. Amanda Kaplan, who is the Vice Chair for Quality in the Department of Family Medicine. She's also lead physician for immediate care at North Shore University Health System and a clinician educator of family medicine at the University of Chicago. Dr. Maggie Collison is a physician in internal medicine and infectious disease specialist at North Shore, and she's also a physician scientist who will be joining us. And Professor Subhash Tay is a professor at the Pritzker School of Molecular Engineering and the Institute for Genomics and Systems Biology at the University of Chicago. And the Tay Lab has a range of drug discovery, repurposing research that he will bring to the table as well. So if we can go to the next slide. So based on the lecture that we saw today, and this is to the panel, I'd like you to address first, what are the implications of this research and the body of work on ambulatory COVID-19 antiviral medications for health equity, based on your own expertise and observations? And that's open to the full panel.
So I think from a health equity point of view, the research that was presented was pretty well-rounded in the groups that it was looking at. I think the biggest issue comes in that requirements for all of these treatments require testing and the ability to access testing to be eligible for any of the treatments that are here. So that's definitely been a huge issue with where can we provide these treatments? How do we get patients into our system? What's going to be the reimbursement, which thankfully there was government funding for a lot of testing at the beginning of the pandemic and is still ongoing at this point. So as long as that continues, that reduces some of the cost barriers, but just access. Our own immediate cares were very overwhelmed through most of the pandemic with being able to stay open even for a few hours to meet the demand of people who needed testing for their symptoms. For specific treatments like monoclonal antibody therapy, we initially at North Shore were able to provide those in the emergency room, but then had to move it out to an outpatient location due to volumes in our emergency rooms. And we were really only able to have enough staffing to provide this treatment at a central location in our Skokie office. We were not able to provide this out at the edges of the North Shore system, which we know we have very, very different populations and socioeconomic status based on location within North Shore. So that was a huge issue for us of being able to just provide this treatment equitably across our system. Was probably the biggest issues we have with health equity in prescribing these kind of therapies.
Thank you. And I imagine, in a well-resourced system like ours, that access might be vastly better than in lower resource communities or in communities that may be going through FQHCs where the type of setup that we have here may not be as advanced. Any thoughts about that based on what we've seen across Chicagoland?
Yeah, I think it's always interesting to me when working for a well-funded system like we do that there still wasn't the staff available to be able to provide these treatments. So I can only see that incredibly compounded at less less outfitted institutions. Because even here at North Shore, we really struggle with just having the staff available and healthy enough to be able to administer this. So that's, yeah, so I can only imagine that it's been significantly worse. There was also the allocation. So for those of you who don't know, all of these treatments are being allocated by the state and hopefully distributed equally among the different communities. And I know they were definitely making health equity a major pillar of how they were distributing medications, especially the oral medications across the state. So just that dissemination of the medication itself definitely played into certain health equity issues.
Thank you. Dr. Collison, thoughts on health equity implications?
Yeah, I mean, I think throughout this pandemic, I think we've all been continuing to see kind of before our eyes the disparities that have been going on within our city, within our country, of course. So I think, all of that, like exactly what Dr. Kaplan was saying, I think that logistically, like you're saying, in any environment, it's hard to get. We worked at U Chicago before, so even we were didn't have a space to even do infusions. And then I remember even hearing on kind of the radio, maybe it was Northwestern or I forget another, I think it was University of Wisconsin. They were interviewed and talked about how they were trying to find the times that they could safely administer to people that were positive and separate them from patients that were coming in for other, an infusion center might not be the ideal place because a lot of times having high risk patients. So I think logistically that's been very hard. But then I think with the pill medications, I think there's still been a lot of honestly, just in my own experience, confusion about how to prescribe it, how do I order it, I work in infectious disease and have people right next to me that could walk me through it. But I could, imagine, I think that's been another area where a lot of people, I think a lot of times of our STIs, I have more experience kind of working in that environment and how they're trying to kind of move towards people being able to just get a test and get treated without necessarily having a primary care or not, access to all of that, because that is limited throughout different areas of the city, different areas of the country. So I think that is still like a major issue, is just access to a provider. And I know the test to treat program, which I'm not an expert on, but I know that I think one of the goals is trying to get that for people. I don't know if anybody else here knows anything more about that, or if any other providers that are on this have had any other similar issues.
I think the other thing I can speak to with health equity is back in the fall when when this Omicron surge was, or sorry, the original surge was coming through and we were using Regeneron. The surge happened so quickly and so overwhelmed most systems around the country and the world, where NIH had to put out what to do when we're rationing care. We needed to get guidelines on how to ration that care. And patients were the first to bring health equity up as a concern. A lot of patients I had to turn away immediately asked for, what criteria are you using? Are you taking health equity into account? They were very, very educated on how a system should be trying to equitably distribute these resources. So that was very impressive to me, how on cue patients were to asking those really hard questions of, how did you decide to give this drug to someone else and not me? So the patients are definitely very well attuned to this subject as well.
And then even within a health system, there can be patients who have, say, public health insurance instead of private, or they may have other social determinants and challenges that may make it difficult to access care in terms of information, and building that into dissemination implementation becomes a challenge. But Dr. Tay, are you able to, is your audio working? So we can go to the next question, which is, based on your work and what you saw today, what are your thoughts of the implications of this work for dissemination implementation in the future, given all these challenges and complexities and the risk stratification and so forth? What would you like to see happen in this space over the next year? As I realize this is a very kinetic process, and
I know I would really love to see better direction. I don't think when I offered to try to help make these therapies available at North Shore, and there were many people before me who had done all the hard work to try to set these up, I was not prepared to be the one making these decisions from a higher level. I'm a primary care doctor by trade. So I think even still at North Shore, there's a lot of people who have opinions about how this should be brought, but only very few who actually have the resources to make it happen. And so I would love to see that all of us kind of have more streamlined processes of who's making these decisions, how we're getting the information. I beg for information from, my boss, who is part of IDPH and is able to get all of the quick kind of information from IDPH and the FDA, and I have to kind of ask him to send me all his emails so I can be up to date, so I can make these decisions of what we can offer and how we're going to put it together. So I felt like on some level, I feel like the CDC did a great job of communicating a lot, but there's still information that is being kind of withheld or only distributed to certain groups, when kind of this has come down to the common primary care doctor needs to be aware at every single step of where we're at, where are we going, what's the trial, what are the trials saying, what's available. It can't be filtered down anymore just through certain channels. It needs to be democratically distributed to everybody, because we're all being asked these questions from patients, and we're all being asked to do work that may be well beyond the scope of what we originally trained for. So I'd just like to see, that that's democratic and equally distributed, and, that all of these institutions like North Shore can really put together streamlined paths of who's going to make these decisions and how are we going to make sure everyone's on board and everyone's opinion is being brought into the fold. When I started doing monoclonals, I had every specialist kind of after me, if you need to get my patient in, no, it's the renal transplant patients, no, it's the pregnant patients, and all completely valid, but it was all being, it wasn't streamlined. And so it made it very difficult to help the most amount of patients, and who really fell to the top of that priority list became very confusing.
And in other health systems, perhaps, the providers may not have as much education that's ongoing and built into huddles and things on a daily basis that we may have. So in terms of inequities, thinking about other systems that may not have the level of streamlined implementation that some of these large integrated health systems do, I could imagine that would be an equity issue as well, because there's so much information to handle well, and without understanding the drug interactions, without having provider education, this really can't be done, at least not the right way. So, Dr. Tay, are you able to comment on the health equity implications?
Yeah, absolutely. First of all, I'm really sorry about my connection issues. This is coming and going, so hopefully I'll say quickly. I do think that oral medications actually do improve health equity implications quite a bit. Therefore, there needs to be more research in this direction. As we know, vaccines have not been available to all, or there has been some hesitancy, and this may not be the case for a pill, and therefore this research needs to continue. I have a few things to say on the future translational directions, so I'm going to leave that to that and say that I think overall, drug research should continue, if only for addressing the vaccine hesitancy issues in our communities.
Very good. So thank you. And Margot Quinn had a comment. Dr. Kaplan can also address disparities in access to treatments through clinical trials. For example, clinical trials may need to happen in clinical trial centers that are not near train lines, not near the neighborhoods where many patients who may need the treatments the most live. And so thoughts about the fact that clinical trial access is another pain point in terms of health equity that we need to figure out how to overcome.
Yeah, we were uniquely situated through our immediate cares, which we were able to deal with the issues of having COVID positive patients in our clinics. So we became kind of the hub to do a lot of the clinical trials, at least here at North Shore. And we did our first trial at Skokie, which unfortunately is not on a train line, not at easy access public transportation. We were able to then move a remdesivir trial up into our Gurney location to try to address some of those health inequities from the initial convalescent plasma trials we had done. I think what's been really interesting is studies like the Active-6 trial, where they are able to do everything over the phone and send drugs directly to patients. So I think that's made a huge change, or it's been really beneficial for addressing some health equity issues we had with earlier clinical trials in the COVID.
Thank you. So that leads into the next discussion question, which is, what are the implications of this work for dissemination and implementation in healthcare systems? Some of that's already been discussed as an equity issue in and of itself. But going forward, as the evidence changes and the variants and subvariants change, where do you see this going in the next year? Are we going to be geared up for the next wave any better than we were this time? Or where do you think that health systems need to go in the future?
I can say just from ID. Oh,
Yeah.
no, do you want to go ahead, Savas?
I can
Just
comment
because
on
of
this
your
from an
connection.
outsider.
Yeah.
As an outsider who's not a medical professional, there's so much inertia in our system. I do not think that there's going to be too much of a difference in the next year or the year after. I think we're really well positioned for the future pandemic, unless it comes in the next few years. But I don't see too much of a change happening because of the way our systems work and the huge inertia in everything that was so far described. Yeah.
Thank you. Dr. Collison?
Oh, I will say, I think that, when I think that kind of the very beginning of all this, when we were like just not even able, I was working a lot with just trying to get a test. And I remember the first patient we tested, like we sent it to somewhere and then it got faxed to the wrong hospital, so I feel like within 2 years, I actually overall I'm feeling like there's a lot that's been accomplished, even though I agree there's so much. I think the dissemination, there's been a lot of communication that's been really challenging. There's a lot, unfortunately, of inequalities and that have, been both inpatient and outpatient care issues, I think. But I am hopeful with kind of at least like making these pill. I do think that was a game changer in some sense, because there are people that either aren't able to get vaccinated. Like the vaccine was a big deal, of course, but then also these new, even looking at remdesivir for three doses instead of waiting till people come in later to the hospital. I think that was like a little bit more hopeful information that we're getting. So I am hopeful on an individual basis that if somebody's unvaccinated or if they are immunocompromised, that there might be more tools available to us. I do, like, as the mask mandate on like all planes or whatever got canceled today or something, that we'll have. I think there's a couple of different areas of like the public health side of things, but then I am hopeful that some of these other tools will be in place that we can kind of help all people, whatever the reason is that they're not as protected by vaccines. So.
Right, so we've made a lot of progress, and it's not perfect. There's big equity issues, but some optimism about the next few years in terms of what we learned from this, it sounds like. What would you say are the implications of this line of work, which is very broad, involving multiple drug classes and mechanisms, but in terms of policy in the future, where would you like to see things go? I mean, the big issue that was raised was when emergency use authorization ends, and what will the future look like, or what could they do? At some point, full FDA approval will be needed. So what are your thoughts about the policy implications that you'd like to see? FDA to this federal legislation? So another way to say that is, what are we going to do when the EUAs end suddenly?
Yeah, and if anybody else has thoughts too, happy to hear them. I think, again, I'll have to ask about kind of how long that takes, or, what that entails for the FDA to then go back and hopefully approve some of these. I think that would also be helpful in general. I know, like inpatient, when I work with our inpatient pharmacists, there are some patients that come in that are admitted for other reasons, for non-COVID reasons, although they are positive and have mild symptoms. So they're sort of in this like niche category where we've had to like really follow that EUA like to the T, because like if you don't, it's definitely big. There's no like off label, there's no like way around it right now. So I am hopeful that like eventually getting the full approval will open up a little bit more doors for providers to kind of make decisions for their individual patients, if that makes sense. I don't know if you have anything else to add.
Well, if the FDA, if the rules were to change, or some of the regulations such that post-marketing surveillance could at some point be sufficient for FDA approval, full approval, there's I'm sure a lot of data out there, but a lot of that is in the gray literature and not really available. So I'm wondering if there might be another stream for the FDA to create, because I think to cut this off suddenly, we'd suddenly have no tools to do most of what we've been able to do in the last 2 years, except for vaccines.
Yeah, I think where I'm interested to see, policy go is COVID has, been a very painful but rapid transition, and it's really forced us to acclimate very, very quickly in ways that I felt like there was a lot of resistance to previously. And I'm hoping kind of, necessity is allowing us to think of doing research in ways, doing policy in ways that we hadn't thought of before, while still maintaining kind of rigorous standards for it. And I think as simple as things to being able to get, more video visits going. All of a sudden, everyone pivoted on a dime to be able to make video visits happen and make the kind of the insurance happen for these video visits there have been a lot of resistance to going into this pandemic. So I think of something like that turned very, very quickly from something that was not happening or insurmountable to, yep, we can make it happen. Let's all work together and here we go. I think for research, looking at the novelty of some of these kind of rapid change research protocols are really, really interesting to me, of not having to start everything from scratch for every single new thing, but hey, we have this base population we want to look at. We're going to try this drug, and if it doesn't work after a few months, we're going to switch to this drug. And being able to do kind of some of these more rapid change experimentation has been really, really interesting to me, and allowing us to kind of move not as quickly as this pandemic, obviously, but to move at a much faster pace than we had previously. So I think that's where my head goes when I start thinking of policy. Of we had all of these things that we got forced into doing, but actually ended up working pretty well, and we realized we could move. Could change things pretty quickly, even though we thought those were impossible previously.
Yeah, the science has advanced and changed a lot, and there's a lot of new methods. But I'm just wondering, in terms of funding and other things, whether we're going to need another tranche to be able to get through the next few years and be ready for the next coronavirus or whatever that will be. So in this area of what are the implications of the research for translational research directions in the future, I'd like to start off with Dr. Tay. What are your thoughts going forward based on your work?
Yeah, I think we are in a much better place than we were before the pandemic. And although I'm a little more pessimistic about the next few years, I think the future for antiviral discovery overall looks really bright. I might even say that COVID-19 might have been the best thing for antivirals overall. We didn't have too many before COVID-19, especially oral ones. So we should continue doing this for making impact in the future pandemics, to keep our time. Oral antivirals have been proven to be critical, especially with the remdesivir example. Definitely complementary to vaccines and antibody therapies and other types of approaches. And they do also help address the discrepancy you see in other treatments. And coronaviruses specifically, I think there are many different technological approaches, but those are protease of the virus overall. Those of efficacy, also for basically, reduce creating resistance than those drugs that target other virus. I think we're in a better place. Yeah.
Okay, thank you. We're having some audio issues, but I guess another area here is the issue of repurposing, repositioning FDA-approved drugs, and some of those have found their way into treatment protocols. And Dr. Tay, if you have any comments on that, if your audio is back from your own work using informatics and so forth. But clearly there's some excitement about where we can go in the future because of how much the science has advanced. And so I think that we are probably at the end of our discussion questions. And I'd like to thank the panelists today, unless there are more comments from any of you before we adjourn. Okay. So thank you again for joining us today, and thank you all for adapting to a very different format than what we're used to. I've thought it was a wonderful presentation, a great overview, and also very evidence-based, not just only a review, but presentation of active clinical trials and new research that our experts have been able to bring together today. So thank you very much. For questions, comments, concerns, or requests to present at a future seminar, please contact me. My email is on the slide right there. And I would like you to respond to an evaluation, a survey that you will be sent by email, but there also, I believe, is a link to the survey right there in the chat box. And then we're also going to have a link to the YouTube channel of this recorded session today. So our seminar series will return next month on May 17th, where the topic will be COVID-19 vaccine misinformation, and that will be led by Dr. Roy Perlis from Harvard Medical School, based on some national public survey work. And so I'd like to thank you all again and for bearing with us as we've adapted to some changes in format today. But I thought it was a very informative and enlightening seminar, and I thank you all for the great work that you've been doing. And Rachel, any additional comments before we close today?
No, I think that's it.
So again, thank you all very much, and thank you, Rachel, for co-hosting with me today.
Very welcome. Thank you, everyone.
Okay. All right, bye-bye.